The title of my presentation was How to Prioritize HCV Treatment Perspective from Health Economics. And so what I wanted to try to do with the presentation, these are my disclosures, money from those sources, was to provide the Microeconomic Foundation for the that was used for the prioritization recommendation, and then provide some critique and some evidence related to that foundation, and then potentially point some directions for to look in the future for prioritization. So the foundation for prioritization is the basic idea that resources are finite, so rationing, some type of rationing is required to balance supply and demand. Price is in general the most efficient mechanism used to ration goods. And in the price situation, rationing occurs when consumers use price as a signal to prioritize purchases in a way that maximizes their personal utility. So the idea is in microeconomic theory that without government intervention, this would lead to the most efficient distribution of resources for most normal goods. However, health insurance and health care is not a normal good for several reasons. And it's not purchased within a true free market, as the market's highly regulated and subsidized, and many individuals pay no price for their insurance at all. So what this means is that patients receive little to no cost signal for their medications, putting pressure on increasing demand for the medications and raising their price. In addition, there's additional price pressures in the case of hepatitis C, including limited competition between firms and a backlog of unamortized costs from past cases. So essentially 30 years of cases are showing up today, and because of the ineffectiveness of prior therapies, we need to treat them all, in the next few years. So in terms of the justification for a policy of delay of care or prioritization of care for those in the most advanced fibrosis states, the policy justification sets out a threat, which is that demand for treatment will surge for many reasons. A claim of helplessness, that prices are outside of government control because of lack of price competition and because of current patent laws. And this threat has the potential to throw the insurance system into crisis. So because there's no price mechanism to regulate demand, we would need to have what's called a non-price mechanism or non-price rationing to manage demand. And then the non-price mechanism offered would be prioritization by fibrosis stage. And this is posited to be the solution that would result in the maximum possible societal benefit given a fixed quantity of resources. So based on some of the forecasts and assumptions from this foundation of what was expected to happen to demand and the lack of price competition to push down prices, several academic articles, including one of my own, multiplied assumed increases in demand by assumed future prices and came up with very large, scary numbers that were intimidating to insurance systems. So this is an example from Chatwell from 2015, an AIM paper stating that the large number of HCV-infected persons needing treatment could place a huge burden on health expenditures reaching an average of $27 billion per year, which is equivalent to 10% of all U.S. prescription drug spending in 2012. So what's wrong with this rationale? Should we just accept it at face value? I would suggest that there's at least four major critiques of this rationale. The first one being the financing crisis that result from a new HCV drug or a new drug of any nature should be addressed only by limiting access to that drug. So basically, if you have a new drug that provides new benefits and it's costly and it's creating new costs, your only policy solutions for managing those costs are within the area of the people who are receiving those drugs. So I would argue that this is a policy preference and not an economic theory. And actually the theoretical basis for cost effectiveness research is the opposite of this. So actually the welfare economic basis for that underlies all cost-effectiveness research states that cost-effectiveness ratios can be directly compared to each other by comparing the cost per unit of utility gain. And it can be used to identify superior health technologies so that resources can be reallocated from inferior uses to superior uses, and in that way increase overall population health. So many commonly reimbursed health services, for example, mammograms, PSA tests, and many others, have less favorable ICERs than treatments of HCV patients in stage F0. However, looking at these use of services and reallocating resources from one area to another was never a part of the debate. So why is this? I suggest that the debate when we came into it was much different than what we have now, and it was preset with a set of arguments against what were then called Me Too drugs, and I guess are still called Me Too drugs, but it's a much smaller problem than the blockbuster drugs we have coming. So this is a blog post from the New York Times by an economist named Reinhardt, which was very influential in about early 2013. And what he argued, early 2014, excuse me, what he argued in the paper, without directly saying that hepatitis C was an example of this, but also mentioning hepatitis C in the same paragraph, was that for all drugs and medications, the amount of incremental benefit that you can get with each new treatment that you develop decreases. So in other words, the marginal returns of medical technology diminish as we move forward with medical advancements. And this is very true for something like antihistamine drugs, where the latest antihistamine drug provides some but very limited benefit over the last one. But the question is this the case for hepatitis C medication? So this references a paper that we published with CDC in CID in 2015, where we looked at the incremental cost effectiveness of different regimens to treat hepatitis C going back to PEG-RIBA. And then we plotted them on a plot looking at the cost per additional quality gained on the y-axis and the number of quality-adjusted life years saved on the x-axis, so equivalent to the Reinhardt graph. And what we see is the opposite of diminishing marginal returns. We see increasing marginal returns of HCV medical treatment, representing not a limiting or a limiting amount of benefits to be gained, but a breakthrough technology delivering large new gains, sometimes at lower cost than previous treatments. So then, following that in the Chatwell paper that was published at a similar time, virtually all cost-effectiveness results following that supported the finding that new therapies, new antiviral therapies were highly cost-effective for treating people with HCV, with some minor exceptions in subpopulations. Sort of adding on to this, and I'll talk about prices in a minute, using the same progression rates used in those traditional models, but after adjusting for differences in prices, which I'll tell you about, the ICR of treatment at F0 compared to delaying to treatment until F3 was under $40,000 per quality saved, which is far favorable than many, many health interventions that are regularly performed in the United States. And that result assumes that there's no health consequences from delaying treatment between F0 and F3, and that no one is lost from care during that time. A second critique of the rationale would be that lack of competition would keep drug prices high for the foreseeable future in all of the financial projections. But what we actually see is prices are falling based on shorter durations of treatment, which lead to lower costs. Price for access agreements, and these are a major breakthrough that are widely recognized in the financial sector, but are less recognized in the public health sector. So essentially, private pharmacy benefit managers have already, or within about a month of when AbbVie announced its Vacira pack, had negotiated agreements with either Gilead or AbbVie for discounts on drugs covering approximately 80% of people currently with HCV, and resulting in an average of about a 46% discount in average wholesale price. Medicaid and the VA have received discounts between 20 and 30% through negotiated contracting. And Medicare Part D carriers are a strange bird. So what I often hear is Medicare has no ability to negotiate with drug companies on drug costs. So as a system as a whole, that's true. But the Medicare Part D program is entirely designed as a private insurance program where people buy private plans, and each of those private plans are primarily carried by the same providers who offer insurance for the non-Medicare patients. So although we have not gone in and tested this and looked, this is the next thing on our list to look at, we expect that the discounts paid by Medicare Part D programs would be in range with those in the private sector. The second critique in the rationale was that the surge in demand was a hypothesized surge based on economic theory, but not modeled using economic forecasting methods. Essentially, it was an assumed increase in demand of this percentage or this number of cases per year when traditional forecasting methods could have addressed the issue. So what we've seen is there has been no substantial surge in treatment demand, and actually new prescriptions for antivirals, at least for Harvoni in 2014, range between about 150,000 and 175,000. We were collaborating with Gilead on a project to look at Medicare coverage, looking at their latest numbers. They were expecting earlier in the year when we were talking to them to have NRX numbers of around between 250 and 300,000, but it's looking like they're going to be more like between 150 and 200,000. If you look at the years before the new drugs came out, immediately before there was a little bit of dip in demand when people were waiting for new drugs, but prior to that, when the last era of antivirals came out, and even when PEG-RIBA came out, you saw a treatment rate of about 150 to 200,000 people per year. So why is this happening? We actually don't know why, and it deserves further investigation. So this is sort of the most substantial critique of the rationale, is that even if you grant the rest of the argument that that hepatitis C medications will create a financing crisis for insurers, the idea that prioritization by fibrosis stage is the optimal policy solution to ration HCV treatment is untenable for the following reasons. First, the policy is based on data taken from repeated biopsy observational studies, which are not replicated in clinical practice. So the practitioners who are intended to implement this policy cannot expect the same results that are seen in the cost-effectiveness models that recommend the policy. In fact, current low-cost clinical ascertainment technologies such as APRI and FIB4 are either highly unstable to the point where they're unsuitable, I would argue, for rationing care for a life-threatening condition, or they're expensive, like FibroScan, with the costs of this ascertainment not built into existing cost-effectiveness estimates. So just as like a sneak peek, I don't want to give out the results because it's going to be a new paper, but using actual progression rates taken from electronic health records as opposed to assumed rates from clinical studies, and looking at transitions between APRI equivalent stages to fibrosis stages, or FIB4 equivalent stages to fibrosis stages, as opposed to using the biopsy ascertained information, what we found was quite chaotic movement between APRI and FIB4 measures between years, and observe natural history patterns that do not conform with those in the cost-effectiveness model. So you would see someone with no a priori evidence of fibrosis in year 1. You wouldn't see them at all in year 2, and in year 3 they would come back with decompensated cirrhosis. So either the a priori measurement is wrong, or we don't know about early staging of disease, but I think that we know that both a priori and FIB4 are pretty wiggly. So what are the implications? Case identification and treatment of HCV is a cost-effective strategy to improve health and should be expanded in the United States to reduce morbidity and mortality from the disease. I would argue that the largest problems related to hepatitis C in the US are not financing, but in identifying asymptomatic cases, and more importantly, in linking newly tested positive patients to care. So this should not be that surprising. We had this problem prior to new medications being introduced. We're having this problem after new medications are introduced. That's where sort of the battle is going to be fought in terms of eliminating morbidity from hepatitis C. And the overall financing impact of HCV treatment is also likely to be smaller than feared, as well as spread over a longer period of time. This is both because of a lower rate of demand for services, and because fewer people, and because of lower drop-in costs for medications with increasing price competition. HCV treatment is increasingly efficient and cost-effective. So what do you do instead? Here are some ideas. I would say that the first 3 price competition negotiated contracts and government intervention have all been tried or are in practice already. Reallocation from low-value health services is trickier, so we would need to think about how to do that. But what they do in the UK when they have more demand than they have finances for, and in other countries with single-payer systems or other resource-scarce systems, is they just make a line. And the prioritization scheme is determined by the line, and I would say at this point that's probably better and more ethical than attempting to determine who gets care and who does not get care based on what we know to be inaccurate staging tests. Thank you.